Early onset fetal growth restriction. This is a subject widely spoken about but still confusing. And why do we need to know about the lag in the growth is because we want to deliver a neurologically healthy baby and not just a live baby. So the outline goes like this. We'll know why is growth lag important, how do we identify a small fetus, how do we differentiate FGR from small for gestational age, that is SGA fetus, what is early onset and late onset FGR, what are the tools for surveillance of FGR, these are growth charts and Dopplers, stages of FGR and stage-based management by Barcelona protocol by Gretakos. So why do we need to address this issue of FGR? Because 30% of pregnancies in India have small fetuses and 4 to 8 times at higher risk of perinatal mortality. These fetuses also have a higher risk of pre-eclampsia. 50% would have short-term morbidities like fetal distress, hypoglycemia, hypothermia, polycythemia. And then we have long-term morbidity in these fetuses, which tend to develop adulthood diseases like type 2 diabetes, hypertension, and obesity. Then there is increased frequency of abnormal neurologic development and GI problems after birth in these fetuses. So as much as we talk of aneuploidies, the major chunk of adverse pregnancy outcome arises from FGR and hence the talk. How do we identify a small fetus? So step 1 is to establish the gestational age of the fetus, and then we need to estimate the fetal weight and calculate the weight percentile. Assigning gestational age is beautifully covered by Akanksha, and I'll skip all of this. So once assigned, don't change the EDT in subsequent reports. That's an important message. For fetal weight, we have many published formulae, and the right formula is that which incorporates fetal head, abdomen, and femur measurements. We find the percentile and plot on growth graphs. Small fetus is the one which has a fetal weight of less than 10th centile for gestational age. And I repeat, it is 10th centile of gestational age and not ultrasound age, because ultrasound age could vary in different ultrasounds. Hence, a correct gestational age is the most important factor. And what are these percentiles? So for example, if a 3-month-old baby is in 40th centile for weight, that means 40% of 3-month-old babies weigh the same or less than this baby, and 60% would weigh more. And then there is this issue of chart discrepancy, and we have 83 published fetal growth charts, and 10th centile would vary in these charts. So we have intergrowth chart and headlock chart, which are reasonably good charts, because this has been shown by observational studies across the globe. Of all the fetuses with weight below the 10th centile, 70% are SGA babies with normal fetal-placental function and normal Dopplers and no additional risk of perinatal mortality or morbidity. Most of these are true SGAs or constitutionally small. The remaining 30% are FGR, and out of these 30%, 20% would have uteroplacental insufficiency, and 10% would be small because of some aneuploidy or structural abnormality or infections in the baby. So how do we define FGR? FGR is a fetus with an estimated fetal weight of less than 10 centile on ultrasound that, because of a pathologic process, has not attained its biologically determined growth potential. Now, since failure to attain growth potential is a concept difficult to gauge, fetal size is used as a proxy with all its limitations. And that is to say that genetic growth potential is different, and so is the size. So although size is different, both these individuals have gained their genetic growth potential. So it is not about the size. Size is a proxy of growth potential. Fetal growth restriction is a functional problem of unmet fetal needs because of pathology in the placenta. The fetus is unable to reach genetic potential because of unfavorable environmental conditions, which is nutrition and oxygenation from the placenta. And then we have fundamental differences between FGR and SGA. SGA is physiological smallness, weight less than 10 centile. FGR is pathological smallness with estimated fetal weight or AC less than the third centile, which is a solitary criteria, or the weight in between third and 10th centile with abnormal Dopplers. So are all SGA fetuses FGR? And the answer is no, because SGA would not have Doppler abnormalities. Are all FGRs SGA? And the answer is still no, because there is this group of FGR which we see in AGA fetuses which are appropriate for gestational age. So AGA fetus is the one between 10th and the 50th centile, and they are important because even in between 10th and the 50th centile we have a substantial amount of perinatal mortality. So it's important to look at the dropping centiles of growth velocity and abnormal Dopplers even in this group. How to differentiate FGR and SGA, that is pathological smallness and physiological smallness. This has been covered by the previous speakers, but just to recapitulate, FGR is poor perinatal outcome, SGA have good perinatal outcome. FGR Doppler signs of adaptation are seen because of placental insufficiency. SGA no Doppler signs of adaptation because placental insufficiency is not known. FGRs will deliver around 37-38 weeks. SGA could be carried on till term till 40 weeks. Then we have early onset versus late onset FGR. The definition by Delphi consensus. Early onset is the one which commences before 32 weeks. Late onset FGR commences after 32 weeks. But this is an arbitrary differentiation or demarcation because there is a lot of overlap between early onset and late onset FGR. Talking of early onset FGR, here the placental damage is more than 30%. And placenta, we know, has two compartments, the maternal compartment which is supplied by uterine artery and the fetal compartment which is supplied by the umbilical artery. So the maternal and the fetal compartment supplied by uterine and the umbilical arteries, and these two arteries have a common destination, and so both of these vessels are placental vessels. And there is exchange of nutrients and oxygen in between these two compartments. To define early onset FGR by Delphi consensus and ISWOG practice guidelines, there are some solitary criteria, that is abdominal circumference or estimated fetal weight of less than third centile. So either of the two present alone would classify it as early onset FGR, or there could be umbilical artery absent endogastric flow alone, which would classify it as early onset FGR. When the weight is less than 10 centile, the weight or the AC less than 10 centile, we need some contributory criteria, which are uterine artery PI more than 95 centile or umbilical artery PI more than 95 centile. Either of the two or both of the two or both of them, along with less than 10 centile of AC and expected fetal weight. Late onset FGR has placental damage of less than 30%. So the diagnosis in early onset FGR is easy because the fetus is small in size because there's huge amount of placental disease, and there's abnormal umbilical artery Doppler as well. The problem is with management because these fetuses are premature fetuses, and so we really want to know the time of delivery so that we don't deliver too early and we don't wait long enough for hypoxia or acidosis to set in. These fetuses have 50% incidence of preeclampsia. Hypoxia is very high because there's large amount of placental damage, but tolerance to hypoxia is good. So we could compare early onset FGR with the Sherpa, which is living in a hypoxic condition for a long time and hence has good adaptation to hypoxia. Whereas someone who goes to high altitude from plains where the oxygen concentration is good, so when he goes to high altitude and faces hypoxia, the person faces high altitude sickness because of low tolerance to hypoxia. And this is late onset FGR. Coming to management, we should understand some key concepts. Number one, placenta is a unique organ. 2. Cardiovascular adaptation and brainstem suppression. And 3. Hypoxia versus lung maturity. Placenta, the unique organ. We need two factors responsible for the fetal growth, and these are nutrition and oxygenation. Placental dysfunction is associated with fetal smallness due to malnutrition and fetal compromise due to respiratory hypoxia. So placenta is the nutritional and respiratory organ. Now if we try to understand the need of the fetus in initial weeks or before 32 weeks, there is exponentially higher need of nutrition for the fetus. So nutritional need is high, and this baby, if it faces a placental dysfunction, this would become very small. And so we need nutritional capacity. We use the nutritional capacity of placenta to diagnose FGR. During this time, the respiratory need of the baby is very low. So the baby doesn't suffer hypoxia that much. Whereas after 32 weeks, the nutritional need balances out. It reaches a plateau. So these babies where FGR commences after 32 weeks and placental damage happens after 32 weeks, they are not very small, but they have a respiratory compromise because respiratory need of the baby is exponentially high after 32 weeks of pregnancy. So we use the respiratory capacity of placenta to time the delivery because these fetuses will have problems with CTG and fetal heart rate. Cardiovascular adaptation and brainstem suppression. So in early FGR, cardiovascular adaptation is happening. There is severe placental disease and severe hypoxia because of perfusion defect. There is high resistance in umbilical artery, which is draining blood into the placenta and faces resistance from the placenta. Heart must do more work as it has to push against the higher resistance of the placenta and the umbilical artery. And eventually the heart fails. The right heart fails before the left because it is the right heart with the cardiac output of the right heart which is dependent on the resistance of the placenta, and we will see this as we go by. And ductus venosus becomes abnormal because ductus drains into the right heart and therefore bears the brunt of the right heart. The brainstem. The immature brainstem in early onset FGR is resistant to hypoxia, and therefore CTG and fetal heart rate become abnormal very late after the Doppler abnormalities have set in, because Doppler will be abnormal because of heart issues in early onset. Therefore, Doppler is the trigger for delivery in early onset FGR. In late onset FGR, the mature brainstem is highly susceptible to hypoxia. And the brainstem has cardiovascular and respiratory centers. Therefore, CTG, fetal heart rate and breathing, will be affected early in late onset FGR, even before the Dopplers become abnormal. So CTG and breathing and fetal heart rate are the trigger for delivery. So the late onset FGR, there is mild placental disease and hypoxia. Umbilical artery is normal and the heart is happy. Ductus venosus is normal. The issue is with the brain. Comparing hypoxia with lung maturity. So the aim of delivery is not to deliver too late, uh, wherein hypoxia or acidosis could set in and there'll be long-term poor outcomes. And at the same time, we don't want to deliver too early for the fear of neonatal death due to poor lung maturity and prematurity. So, what are the tools to gauge FGR, to diagnose and to do surveillance in cases of FGR? We have growth velocity curves because growth is a process. So, we want to plot the growth on a curve, and the graphs are important for diagnosis as well as follow-up. So if the patient comes to us with scans from different centers, we need to incorporate those values in our machine and plot them on the graph. Doppler signs are useful for diagnosis of FGR and prognosis because they reflect placental disease and fetal adaptation to hypoxia. So every third trimester scan has to include a Doppler. And those are the growth velocity curves. So this is the curve plotted from 12 weeks to 37 weeks. And we see that this is the growth, which is the velocity and change in size with time. And this one particular dot is the size. So growth can be assessed by these longitudinal measurements. Coming to Doppler indices, we have different vessels. The uterine artery and the umbilical artery are the placental discs, and these tell us about uteroplacental impedance and placentofetal impedance respectively. Middle cerebral artery, ductus venosus, and aortic isthmus are the fetal test, and so is CPR, and they tell us the response of the fetus to adversity. So we have diagnostic Doppler markers which are used for diagnosis, which are umbilical artery, uterine artery, and MC, and we have done this already. And we have prognostic markers in FGR, and these prognostic Doppler markers will tell us when to deliver before 37 weeks. So markers for prognosis are umbilical artery, ductus venosus, and aortic isthmus in case of early onset FGR. And CTG is the safety net because late deceleration we need to deliver. These Dopplers have been beautifully covered by my previous speaker. I'll just touch upon them. So uterine artery Doppler is a screening tool and there is no role of surveillance. And umbilical artery Doppler has a role in diagnosis. When the PI is more than 95 centile, it also has a role in prognosis as the umbilical artery Doppler progresses to absent or reverse end-diastolic flow. Umbilical artery Doppler changes precede CTG changes, but it may fail to identify mild placental disease, that is stage 1 early onset FGR. It fails to identify all forms of late onset FGR as well, where the placental damage is very small. And there are certain tips to doing the umbilical artery Doppler. And these are maternal breathing, fetal breathing and movements and hiccups, and Doppler settings. So in this patient, we see the umbilical artery Doppler is showing absent end-diastolic flow. But if we see this very closely, there's maternal breathing happening and the spectrum is going in and out of the umbilical artery. And that is the reason for the absent end-diastolic flow in this case. So when we stabilize the spectrum by asking the mother to suspend breathing, there is some end-diastolic flow in this case. So it is not a case of absent diastolic flow. it is actually there is some flow there, so it is a high resistance flow. Now, if we say that there's intermittent absent and diastolic flow, it does not happen in singleton pregnancies. So we need to check our technique again. And if the resistance is different in different loops of umbilical artery, we consider the least resistance. And then we need to differentiate the absent end diastolic flow and reverse end diastolic flow. So do not increase the PRF or the filters because the reverse component will disappear in this case, as this has a very low velocity. So just reduce the gain to look at the reverse end diastolic flow. And then we have this 30-70 concept. There is high pulsatility index, high resistance flow in umbilical artery in case of 30% villus damage. 60% villus damage will give an absent end diastolic flow. And if it is reversal of flow in umbilical artery, there is already 70% villus damage. And that is the cascade the umbilical artery follows. And a reversal of flow is also seen as a cardiac function abnormality. So, why are we so worried about absent end diastolic flow and reverse end diastolic flow and differentiating the two? Because absent end diastolic flow corresponds to 60% placental damage, severe hypoxia, and needs to be delivered after 32 weeks. Whereas reverse end diastolic flow represents 70% damage. It gives us suspicion of acidosis and it should be delivered before 32 weeks. And then this counseling part for the patients who develop very early IHGR and umbilical artery becoming abnormal at less than 26 weeks. This has been covered by Dr. Shilpa. But just to revise, if umbilical artery Doppler becomes abnormal as early as 26 weeks, we have just 4 weeks time with us before we deliver. If it is abnormal before 29 weeks, again, we need to deliver before 33 weeks. And if it is the abnormality commences at 31 weeks, we can take the pregnancy till 35 weeks. So approximately 4 weeks time for the umbilical artery to progress to severe abnormality requiring delivery. Now, we also need to look at the trend of umbilical artery. So the graph here is going haywire, but the general trend is upwards. So we'll be worried about this case, but here the trend is downwards. So it is going towards low resistance umbilical artery, so we are happy. Coming to MCA, it is a surrogate of hypoxia. So the question we ask is the baby hypoxic? And this has more usefulness in late onset FGR. MCA below 5th centile is indicative of brain hypoxia and brain sparing effect. In early onset FGR, there is severe placental disease. MCA will always be compensated. So it has no clinical utility. Delivery will be entirely on ductus venosus flow or severe umbilical artery flow. MCA is not used for surveillance. So that is the MCA, the normal flow with high resistance, and in brain sparing effect because of hypoxia, the MCA shows low vascular resistance. And in very terminal stages, the MCA resistance can paradoxically become high because of edema of the brain, but we don't want our babies to go to this extent. MCA waveform is also influenced by breathing and hiccups and the probe pressure, all of which will result in high resistance or reversal of MCA and give us false reassurance. Coming to CPR, this also tells us if the baby is hypoxic, and it is more sensitive to tell us about redistribution of blood in hypoxia than the individual MCA PI and umbilical artery PI. and it is a sensitive marker in late onset FGR, and CPR of less than 5 centile and more so the falling centile is important for late onset FGR to warrant delivery. Coming to ductus venosus, this is a trumpet-shaped vessel which carries oxygenated blood from umbilical vein to the right heart and through the foramen vein to the left heart. So it reflects the diastolic pressure in the right heart. And this is to say that right ventricular cardiac output depends on the placental resistance, whereas left ventricular cardiac output depends on brachiocephalic resistance. And in FGR, the placental resistance increases and the cerebral resistance drops. And so right heart fails first, and this is followed by the left heart. And that is the waveform of ductus venosus. The S wave corresponding to ventricular systole, and D and A waves corresponding to ventricular diastole, and the A wave corresponds to atrial contraction. And the A wave reduces and even reverses if the right ventricular preload increases because of the right ventricular decreased compliance. So the ductus venosus will become pulsatile with absent or reversal of A wave in case of decreased ventricular compliance due to diastolic failure. And this is also reflected in ductus in IVC, umbilical vein, and in CTG. And that is the cascade of ductus venosus, and reversal corresponds to decreased compliance of the right heart. And ductus venosus is the strongest single Doppler parameter to predict short-term risk of fetal death, especially in early onset FGR. We have very little time once we have pulsatile ductus venosus, just 48 to 72 hours to give steroids to the patient and deliver. Aortic isthmus. Now, this vessel has a strategic location between the aortic arch and the ductal arch. And during systole, the left ventricle, which has oxygenated blood, it pushes the blood in antegrade direction through the aortic isthmus, whereas right ventricle, which has deoxygenated blood, pushes the blood in opposite direction in the aortic isthmus during systole. But the net flow in a normal fetus is downwards. And in diastole, the flow in aortic isthmus, the direction will depend on resistance of placenta and cerebral vessels. So in a normal pregnancy, the placental resistance is low and the cerebral resistance is high, and the flow is antegrade. So there are four opposing forces acting on aortic isthmus. In systole, it's left ventricle and right ventricle, and in diastole, it is placental resistance and brachiocephalic vessels resistance. And it is a watershed area, meeting point of four variables. And this is where you can interrogate aortic isthmus in sagittal view or in axial view. And the waveform can be explained as the upward stroke because of forward flow from the left ventricle, the dip there because of the backward flow of the right ventricle, and then there is an end systolic reversal, the short reversal there in a normal pregnancy towards in later half of the pregnancy because of right ventricular preponderance. In diastole, there is forward flow in a normal pregnancy because placental resistance is low. But in cases of FGR, when the baby wants to maintain oxygenation of the brain, there could be reversal of flow in aortic isthmus as it pushes blood into the brain vessels. Now, we must remember that the right ventricle pushes blood in opposite direction, and right ventricle carries deoxygenated blood. So it is the deoxygenated blood which is actually going to the brain when reversal is happening. And so there is poor cerebral oxygenation in case of reversal of flow in aortic isthmus, which leads to poor neurological outcome. And that is the cascade, the normal flows progressing to reversal of flow in the diastole in aortic isthmus. And so reverse flow in aortic isthmus is a marker of poor neurological outcome in FGR fetuses. And the reversal precedes ductus venosus abnormality by 1 week. But there are some pitfalls. The net reversal in aortic isthmus happens only after severe umbilical artery abnormality, and it is highly specific but not sensitive. So if we have normal flow in aortic isthmus, normal antegrade flow, it is reassuring. But abnormal retrograde flow in aortic isthmus does not always predict cerebral damage, because there are multiple players acting on this watershed area, and it is difficult to predict that which player is faulty. So aortic isthmus is actually awaiting stronger evidence to be used in daily practice. Coming to management of FGR, the important thing is we need to balance between intrauterine hypoxia and premature delivery. So timing of delivery is important. We have to deliver electively with lung maturation. And so we need to follow a stage-based management protocol, which is given by Barcelona by Gratakos. And why we follow the stage-based management protocol is to reduce clinical practice variation and to maintain uniformity in practice, so that we all are on the same page and we all understand each other's language. And we have this app of Barcelona, or we could go to website of Barcelona and put in all our values and findings, and it will tell us when to follow the patient and when to deliver. We must also realize that chances of survival without handicap increases by 2% per day of intrauterine life before 28 weeks, and 1% per day from 28 to 32 weeks. So it's important to maintain the fetus intrauterine as long as possible. So now we come to the stage-based classification and management of FGR. And for gestational age fetuses which are less than 10 centile, actually between 3rd and 10th centile, fortnightly Doppler is good enough, and we can take these pregnancies to 40 weeks because they have good perinatal outcome. Stage 1 FGR, which is early onset, early hypoxia or mild placental insufficiency. And these are the fetuses with the weight less than 3rd centile, or uterine artery more than 95th centile, umbilical artery more than 95th centile, CPR less than 5 centile, and MCA less than 5 centile. Weekly monitoring is required for these fetuses, and labor induction should be done if the fetus has reached 37 weeks. Stage 2 FGR, or severe hypoxia or severe placental insufficiency. Here there is absent end-diastolic flow in umbilical artery and reversal in aortic isthmus. The fetus should be monitored twice a week. So remember stage 2 and 2 here, it's twice a week. And if it's already 34 weeks, we could deliver. Stage 3 FGR is when acidosis is beginning to set in. So it's early acidosis with advanced fetal deterioration. And we have reversal of flow in umbilical artery and high resistance flow more than 95th centile in ductus venosus. Monitoring should be done every day or alternate day, and delivery should be done if the fetus has reached 30 weeks. Stage 4 FGR is severe acidosis, and here we will have reversal of flow in ductus venosus, and we'll have abnormal CCTG and fetal heart rate decelerations. And we have to monitor these patients morning and evening, and we need to deliver them even when they are just 26 weeks after giving steroids. So to summarize the stages of cardiovascular adaptation, stage 1 FGR is weight less than 3 centile or mild placental resistance and redistribution. So CPR less than 5, MCA less than 5, uterine artery more than 95. And in stage 1, ductus venosus of course is normal, but umbilical artery may also be normal. And all late onset FGRs show this kind of configuration. In stage 2, we have absent and diastolic flow and reversal in aortic isthmus, and here the placental resistance is high and redistribution is taking place, and ductus venosus is normal. Stage 3, there is high resistances in ductus venosus and reversal of flow in the umbilical artery, and this is early acidosis. And stage 4 is when the acidosis has advanced and ductus venosus shows reversal of flow, and there is CTG decelerations of reduced short-term variability, and there is heart rate decelerations. So what is the right time to deliver in early onset FGR? Early onset FGR has severe placental disease, umbilical artery will be abnormal, brainstem is resistant to hypoxia, and CTG abnormality therefore happens late. Ductus venosus abnormality will happen earlier than CTG in all probability, and so we need to deliver on the basis of ductus venosus, and umbilical artery is the safety net. So sometimes we deliver for reverse flow in umbilical artery, and then ductus venosus reversal is an indication for delivery. And then we have this magic figure of 32 weeks. So 32 weeks is universally accepted as timeline beyond which we do not worry about lung maturity that much. So you deliver hypoxias after 32 weeks. So we wait until after 32 weeks for hypoxia. Before 32 weeks, we are more worried about the baby dying outside the uterus because of lung maturity, which is not achieved. So before 32 weeks, we deliver only when the situation inside is too bad. That is stage 3 or 4 as FGR, which is acidosis. So for stage 1 and 2, which is hypoxia, deliver after 32 weeks. For stages 3 and 4, which is acidosis, deliver before 32 weeks. And within this, between 28 and 30 weeks, we would deliver for DV reversal, and between 30 and 32 weeks, we would deliver for reverse flow in the umbilical artery. And this is the summary of what all I have spoken. SGA fetus, all the Dopplers are normal. Stage 1 FGR, the umbilical artery could be normal or abnormal. MCA and uterine artery and CPR are abnormal. Any of these could be abnormal, and monitoring should be done weekly, and the patient should be delivered if it has reached 34 or 37 weeks of maturity. Stage 2 FGR, we have abnormality in the umbilical arteries in the form of absent flow and reversal of flow in aortic isthmus. We need to monitor these fetuses twice a week and deliver them if they have reached 34 weeks. Stage 3, the determining factors are reverse flow in umbilical arteries and high resistance flow in ductus venosus. They should be delivered if they have reached 30 weeks, and the monitoring should be done daily. And stage 4 is about reversal of flow in ductus venosus and pulsatile flow in umbilical vein and CTG abnormalities, and they should be delivered even when the fetus is at 26 weeks after giving steroids. So to conclude, early onset FGR, the heart bears the brunt. Because the immature brainstem is resistant to hypoxia. So listen to the heart. Whereas late onset FGR, brain bears the brunt because the mature brainstem is sensitive to hypoxia. So listen to the brain, listen to abnormal CTG, abnormal fetal heart rate, abnormal biophysical profile, abnormal NSTs. Thank you very much.